Hello and good evening, everyone. Welcome to our 76th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia in collaboration with Ethiopian Society of Hematology and Oncology. Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader who creates the skills through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Yenot Adela, a general physician and first aid trainer from Blue Hills Ethiopia. It's an honor having Dr. Mamude Dinkiye Ali here back with us again to present on the topic ethics in pediatric oncology breaking bad news. So you might remember Dr. Mamude has presented previously on blood and blood components transfusion. If you have missed his previous presentation in session, you can find it on our YouTube channel. So Dr. Mamude Dinkiye is an assistant professor of pediatric hematology and oncology at St. Paul Hospital.
Thank you so much, Blue Hills Ethiopia, for organizing this wonderful activity. Without taking time, I will go directly into the topic, ethics in pediatric oncology, and we will also briefly talk about breaking bad news. These are the objectives of my presentation. The major objective is the participant to understand ethics in pediatric oncology setup. The specific objectives: understand the role of service providers in pediatric oncology ethics. Define ethics and the clinical ethics in pediatric oncology. Describe ethical principles in pediatric oncology. Describe basic principles in medical ethics. To describe components of code of ethics in pediatric oncology, and to discuss how to deal with ethical dilemmas, and finally to describe counseling process and the steps in pediatric oncology. To start with a summary, pediatric oncology service providers care for children with cancer and help children and their family to cope with cancer treatment process. As you know, cancer treatment is one of the longest processes in medical field. So we need continuous engagement with the patient and the families. So during this process, we have to have skills so that we continue with a smooth process. Service provision starts from the moment of diagnosis and during the treatment process, and even for many years afterwards until they are adults. Children with cancer are among our longest term patients. Family members and the service providers are the closest contact with pediatric cancer patients. And ethics in pediatric oncology has inherent challenges. Moral responsibility to ensure that the best ethical decision-making process is in place to meet patient need, uphold the philosophy of institution, and preserve the integrity of profession. In this case, we have to keep a balance of interest of the patient, the philosophy of the institution, and integrity of our profession. In pediatric oncology professionals, we go beyond application of technical and scientific knowledge. It is not only about giving prescription, giving laboratory tests, doing imaging, doing procedures. It is beyond. we have to offer children and their family humanized care aiming at promotion of health, quality of life, comfort to the patient and the family, and their well-being. So we have to act beyond our usual education of knowledge. Coming to the introduction, currently children cancers in under 15 years of age represent about up to 4.6% of total number of cancer cases in population, with a global incidence rate ranging from 50 to 200 per million children per year. Every day, 43 children are diagnosed with cancer. Approximately 15,600 children are diagnosed per year. Child cancer affects all ethnic, gender, and socioeconomic background. There is no discrimination. More than 40,000 children undergo treatment for cancer globally every year. When we come to Ethiopia, according to the hospital records published in 2015, there are more than 150,000 cancer cases per year, of which around 8,000 of them are in pediatric age group. Therefore, it is necessary to seek improvement in services provided to treat them properly. You know, the cancer cases, the incidence is increasing globally as well as in our country. With the family as being the primary caregiver of children, cancer diagnosis affect not only the patient or the child, the entire individuals involved in care of that child, including the health professionals. They need special treatment and a special approach during the process. Coming to ethics in pediatric oncology, ethics, when we say ethics, it is according to Oxford definition, ethics, what is right, what is wrong. When we come to the individual level, it is referring to morality, moral, what is right, what is wrong in a particular society, moral. When we come to a larger scale, value will also come. Value at society level, what is the value of that society? The value in Ethiopia may be different from the value in India or China. The value varies from place to place. The moral also depending on the value of the society. When we are discussing ethics, good to know the religion background of the people which you are serving. The religion also matters. The culture of the society matters. The tradition of the society will matter. So ethics is not something only right and wrong. So it is a branch of bioethics that analyzes moral aspect of decision made relating to the health care of children. That morality is very important. In general terms, when we come to adult, the principle of autonomy will apply. Adult patients will decide about the management of their own health problem. But when we come to the children, it is parental centered. The parents will have a big role in decision making. Pediatric oncology ethics is distinct because pediatric clinician has an independent fiduciary obligation to act in younger children's best interest. That moral precedence over the wish of the parents. Sometimes the parents will go against the best benefit for the child. In this case, with due discretion, with continuous process, the physician who are caring, the nurses who are caring for pediatric cancer patients should come to the consensus, the same agreement with the parent so that the process goes smooth. So we have extra responsibility as far as keeping the best interest of the children which we are treating. Approach to ethical issues that arise in pediatric practice must include respect of parental responsibility and authority. We should not ignore the parental responsibility and the authority while we are keeping or maintaining the best interest of the child which we are caring. So we have to balance, and as much as possible we have to reconcile if there is any disagreement between the best interest of the child as well as the parental interests. There are skills required by service provider as far as ethics is concerned. Interpersonal skill. We have to have a very good interpersonal relationship with the patient and with attendants and with the relatives. We have to have observational skill. We have to have a skill of reading the body language of the family as well as the child, observational skill. We have to be very good and efficient communicator. We have to be emotionally intelligent. Emotional intelligence means we have to keep ourselves in the shoe of the patient. Emotional intelligence. We have to be creative. If one approach is not working, we have to design, we have to find a way, in a creative way, alternative approach to solve a certain ethical issues. There are few important roles which the service provider should provide. Number one important role is provision of adequate and comprehensive information to the parents so that they will make free and fully informed decision about the treatment plan. That is very important. That is what we see most of the time. We don't give adequate time to talk and communicate and listen to the patient and the caretaker. That is very important. Possess the virtue of patience. Are we patient? Courtesy of care of pediatric oncology patients. We have to give them time. There is no rush in oncology care unless it is emergency. We have to give time. Individual, for a group, for a family, we have to be patient. We have to respect sometimes a decision. And we have to listen to them also. We have to have emotional and social skill to be able to communicate professionally with the patient as well as with the family. All in all, we have to know very well what we are dealing about the diagnosis, about the stage of disease, about the prognosis of the disease. We have to be well informed, otherwise it cannot be complete. We have to understand in total the problem of a particular patient. You have to utilize knowledge about oncology diseases to provide education for patients and the families on how to best aid in management of their diagnosis. The family, the patient, should participate in the management of their own health problem. So you have to inform them. You have to give them adequate information, adequate treatment roadmap, and we have to involve them in decision-making process. However, sometimes we experience moral distress. Moral distress occurs when one knows the ethically correct action to take but feels powerless to take that action. Moral distress is characterized by emotional exhaustion, depersonalization, and personal accomplishment. Moral distress is sometimes which we face. It will contribute for burnout of health professionals who are dealing with chronic patients. How to deal with moral distance, very important. Number one, we have to recognize the situation. We have to be aware of the complexity related to the patient's family and the care team. Recognize why this thing happened. We have to understand the complex situation around the patient and the family. Recognition. We have to release, consider what you can change and what you cannot. Let the past experience go that are not helpful in the current situation. We have to release. We should not stick. In the earlier slide, I said we have to be creative. If one approach does not work, we have to create. We have to look for alternative approach. We have to reconsider alternative way of approaching a certain issue. And we have to restart fresh. We should not give up. We have to start fresh approach, fresh way of doing things. We have to bring fresh ideas so that things can get going smooth. Some ethical challenge in pediatric oncology. There are many, but some of them like observing children's pain and suffering. Children, they feel pain, they suffer because of repeated infection, because of diseases, because of the disease itself, because of procedures, they can suffer. This is some of the challenge which the service providers see day to day. Caring for a dying child. Sometimes children get worse, the condition advances and become terminal. It is another challenge. End of life and event of death. Some ethical challenge in pediatric oncology, like observing children with pain and suffering. Pain management is not up to standard in many institutions in Ethiopia. So a good number of our cancer patients are suffering with pain and this is undertreated. So this is a challenge. Or sometimes the family perception of pain in children is also different. The other challenge is caring for a dying child, whether to continue life support or not. It is another ethical challenge. End of life and events of death to the family and to the patient. It is another challenging area in pediatric oncology. Working with and supporting parents, it is another challenge because we have families, extended families, big family members. So when one person is sick in the family, directly or indirectly, other family members will be affected. So this is a challenge in our situation. Being involved in delivery of inadequate or inappropriate care. Our situation has a lot of challenge in availability of the necessary resource for investigation, for treatment, and for follow-up. We are practicing in an environment which has a lot of constraints, so this is a challenge to our situation also. Components of code of ethics. Number one is accountability and responsibility. After all this, the service provider is accountable and responsible for the action which is taken. Respect of right and the dignity, right of the patient. And we have to respect their dignity. We should not undermine what is their personal or humanity. So all these things should be respected. Confidentiality in information. All information should be kept confidential. And we have to also advocate for the best interest of our patient, for the best interest of patient outcome. We have to have advocacy role in our ethics. Professionalism and the professional development. We have to act in a professional way and we have to work towards our professional development also. The basic principles in medical ethics is known. Autonomy, respect of client's wish. The client is autonomous for what action has to be taken toward their management. So autonomy, especially for adults. When you come to children, the parents, the health service providers, and those people who are concerned with the child well-being are also taking part. Beneficence, desire to do good, best interest, something good for the patient and the family. Beneficence. Non-malfeasance, the obligation to do minimal or no harm to the patient. That is non-malfeasance. Justice means fairness. Fairness in all aspects, for all community, for different age group, for different sexes, we have to be fair. So whether it is research or service delivery, we have to respect these basic principles of medical ethics. Some of the ethical dilemmas in pediatrics under treatment of pain it is a big challenge, especially in our situation. Truth telling is another challenge because of lack of information or because of lack of experience. People will get shy in telling the truth to the patient and the family. Informed consent is another issue, especially in pediatrics. Consent, assent, at which developmental level, for which group of patients, in medical condition, all those things are challenged. Minor assents, advanced directives, conflict when there is disagreement in care between medical personnel, utility of treatment, withdrawal of life support. All these are filled with a lot of dilemmas. There are steps for resolving some of the dilemmas, like identifying the problem as you see it, as depending on the prevailing context, the family situation, the medical condition, our facilities, our resources. All those things should be taken into account. Get the story right. Ask yourself, is the problem is regulatory? That means we have to compare with the children's rights. Compare the issue of specific rules, laws of the institution, laws of the country. There are some we need to know very well. Identify who has the power and the controlling situation in decision making, the parent, the caretaker, the relative, or the patient, or the health service provider. All those things should be clearly known. Identify what is in your control and what is not. We need to identify our resources. Make a list of possible actions and their positive and negative consequences. That is accountability and responsibility. Make a plan that you can defend professionally and ethically, and take action and evaluate your plans as you proceed. This is good for subsequent practices. This can be developed during practice. Coming to counseling, good to know about hygiology. Hygiology is the study of problem of normal people and the prevention of incidents of serious emotional difficulties by supporting normal people. This is hygiology. So counseling is more appropriately concerned with hygiology than with psychopathology of behavior. It is very important. Counseling is more appropriate for normal people. Counseling, as you know, it is a process. It is not an event. It is a process. It is a continuous process which is involving interpersonal relationship between therapist, in our case, the service provider, and the patient and the relatives and the family in a humanized way. And at the end of the day, the whole aim is to improve the mental health of the patient as well as the family. So counseling is a process which involves interpersonal relationship. Good communication is key. We need to be emotionally intelligent and we have to be well versed with the situation which we are dealing with. Counseling Counseling is a process, as it is already said, and it has stages. We have 5 stages of counseling: relationship building, assessment of the situation, goal setting, and intervention. We evaluate an intervention, then termination and follow-up of the patient. Bad news. Bad news. What is bad news? It is any news that can drastically and negatively alters the patient's view of her or his future. That is bad news. Bad news is stereotypically associated with terminal diagnosis, but we sometimes encounter in other conditions to which we are going to discuss. Breaking bad news. How a patient responds to bad news can be influenced by the patient's psychosocial context. It is not whether that is about the disease outcome or the prognosis or the seriousness of the problem. It can also be affected by other issues like inappropriate time, something coming in an appropriate time. For example, unstable angina is diagnosed in a parent whose daughter is going to wed in a week's time. This is bad news for that family. Or diagnosing movement disorder in a cardiovascular surgeon. It is going to affect the entire life. Or Parkinsonism in a cardiovascular surgeon or a plastic surgeon. This is extremely bad news for that particular person, but it may not be as such bad for other conditions. So it depends on the context and the situation. Breaking bad news. Patients generally desire frank and empathetic disclosure of terminal diagnosis or other bad news. Empathy. Empathy is very important. Dr. Dagin, empathy and sympathy, different. Sympathy, empathy. We have to empathetic. We have to be in a shoe of the patient or the family which we are dealing with. Empathy is very important. Okay? Focus on training communication skill. When we are dealing with bad news, communication skill is very important. Technique of delivering message is very important. So that we improve, at the end of the day, we improve patient satisfaction and the physician will be comfortable. So this is very important. It is not a science. It is a kind of art. Communication is art. It is art. It is not only science. It is art. We have to be emotionally intelligent. We have to be empathetic. And we have to be communicating very well. And we have to equip with communication skill to the patient and the family. There are ABCD of breaking bad news. ABCD is a stage which we have already discussed, advanced preparation. We need to get prepared before breaking bad news. We have to arrange adequate time and pace and the privacy. Confirm medical facts. We need to have all the necessary information at hand about the situation of the patient. We need to review relevant clinical data, and we need to be emotionally prepared for any eventualities. Ourselves, we need to be emotionally prepared when we are breaking bad news. Building therapeutic relationship. B is building therapeutic relationship. Identify patient preference regarding the disclosure of bad news. Communicate well. C is communicate. Determine the patient knowledge and understanding of the situation. Listen, talk. We need to more of listening than more of talking. Proceed as the patient pace. If the patient does not want to listen, we have to pause our talk. We have to give ample time to listen. Avoid medical jargon or unnecessary wording which the patient cannot understand. Allow for silence and the tears. If they want to cry, you have to give them time to cry. You have to give them time to think. And you need to answer their questions. D is dealing with the patient and the family reactions. Assess and respond to emotional reactions. Empathy with the patient. It is not only sympathy, empathy is very important. Encourage and validate their emotion. Offering realistic hope based on the patient's goal. Deal with your own needs also. Okay, that is E. We are going to go one by one because this is what we are practicing in our daily practice. Advanced preparation, familiarize with the relevant clinical information. When it comes to cancer, we need to diagnose. We have to make sure that this is a cancer. We need to know the stage. We need to know the risk. What are the expected complications and what is the outcome of any intervention. So we need to have adequate information. Ideally, have the patient charge all pertinent laboratory data on hand for reference or for showing the patient. Be prepared to provide at least basic information about prognosis and the treatment option. Because they will ask, what is the solution and what is the outcome of the intervention? Mentally rehearse. For those who have no experience in counseling, we have to rehearse. Or we have to have good experience with experienced counselors before you do counseling. Just like presentation. When you do your first presentation, we have to rehearse. With repeated presentation, we may not need to rehearse. Just similar counseling. When we are starting, we have to rehearse how to do things. Arrange adequate time, private place, and comfortable location for the patient and for the family. No interruption during the counseling process. No other duties. No faulting, no answering. And we need to prepare emotionally for any eventualities. Building therapeutic relationship, determine patient preference for what and how much they want to know. We need to know their perception about their own problem before we talk. And we need to know how much they want to know. This is very important. When they want to know. And we need to know whom they prefer to be present during that process. All those things should be known. When possible, have family member or other support person present. This should be at patient discretion. If the patient does not want, the patient can be counseling alone. If the patient wants the presence of other people, that can be allowed. If bad news is anticipated and how they would like the other to be involved. Okay? This is very important. Use touch when appropriate, but sometimes you have to consider some religions, gender issues, all those things before you do those things. That is why we said when we deal with ethics, there is morality, there is societal value, there are religion, there is culture, there is tradition. All those things should be taken into account. Be sensitive to cultural difference and the personal preference. Avoid inappropriate humor or flippant comments unless you are very familiar, very close to the people you are dealing with. Depending on relationship, you can add some humors if you want it will help. If you think it will help. Introduce yourself to everyone present. Introduction is very important. Relationship with the patient should be known. And foreshadow bad news. Sometimes foreshadow bad news. If you are disclosing bad news, you have to foreshadow by saying, I'm sorry. You have to start like this. I have bad news for you. In a polite, in a compassionate manner. Assure the patient you will be available to support them. You need to schedule follow-up meeting and make appropriate arrangement with your office. Advise appropriate staff and the colleagues of the situation also, or those who can be involved in the support to the patient. Communicate well. Communication is a very important skill during counseling and breaking bad news. Before you tell, ask what the patient or family already knows and understand about the situation. Should start by asking about their knowledge of the situation, about their perception of the situation. You need to find out patient expectation before you give information. What do they expect? You need to speak frankly but compassionate. Frank but compassionate. Avoid unnecessary medical terminologies or jargons. Allow silence or crying for any emotional events. You should give them time. Proceed at the patient pace, not at your own pace. You cannot give them only 20 minutes for counseling. If they want more time, we need to give them more time. Have the patient tell you his or her own understanding, what you have said. That is, they have to reflect. That is another way of knowing whether they have understood the situation or not. So you have to ask the patient, you have to give them time to reflect what was being discussed. Encourage questions. Encourage subsequent visits and be available to support them. Dealing with the patient and the family reactions. They can react, they can cry, they can fall down. So you have to be ready for dealing with such issues. You know the processes which the patient undergo when there is bad news for them. The first thing is they will be shocked. They will be locked, shocked. Then they deny the situation. Then subsequent following, they blame something or someone. Then they internalize, intellectualize. Then finally they will accept. We have to know that all this process will take place in a patient or in a family when we are breaking bad news. Be observant. We said previously, be observant about the body language. Okay? Their interest, their reactions, their emotions. We have to be observant. With subsequent visit, monitor patient emotional status. When any issue of adverse psychological issues like depression or suicidal ideation is very important to observe. Always we have to be empathetic. It is appropriate to say, I'm sorry. You can also say, I don't know. Empathy. Okay? Empathetic. Crying, you may cry, but your crying should be justified. It should not be for your own problem. It should be to support. If it is for the patient issue, you can cry. Do not argue with or criticize others. We have already said some of the challenge. Professionals may disagree, but they should not disagree in front of the patient. They can discuss issues in another session, but not in front of the patient. Avoid defensiveness about action of your own or your colleague. You should not defend. If there is something wrong has happened, you have to accept. For the right, we have to explain, but we should not be defensive. Encourage and validate emotions. Offer realistic hope. Hope. Always offer hope, but that hope should be realistic. During counseling process, you have to offer hope. Even if the care is not realistic, offer hope that palliative care is available. Encourage other available options, religious options, traditional options, family support, other support group options. All those available options should be offered. Discuss treatment options at the outset and arrange follow-up meeting for decision making. And explore what the news means to the patient. What is this news? As we said, movement disorder in a driver or cardiothoracic surgeon is serious, but movement disorder in somebody else who is not requiring fine movement may not be as such serious. So we have to contextualize. Inquire about the patient emotion and spiritual needs. If they need spiritual support, they should be linked, or the spiritual people should be involved. Or cultural people, if they demand that one, they have to be involved. So referrals can be offered if they wish. Use interdisciplinary service. The disagreement between professionals can be better solved through multidisciplinary team meeting. This is very important. Hospice care, palliative care are available options for terminal patients, but hospice care should not be a way to disengage from the patient. We should be always available to support until the last minute of their life. Thank you so much. This is briefly about pediatrics, oncology, ethics, and breaking bad news, as well as counseling. Thank you so much for listening.
Yeah, thank you very much, Doctor, for the amazing presentation, and the topic was an important one, as well as most healthcare professionals would face it on a daily basis. Thank you very much. So we can move on to the question and answer section. So participants, if you have any questions regarding the topic, please write down your questions in the Q&A in the chat box so doctor can address them. So there's one question. So what is the experience in the setting where you practice in regards to breaking bad news? Are we really breaking bad news as recommended?
Thank you so much. This is very important, and because of a lot of issues, constraints, many centers and facilities, we are not applying the standard because of a lot of issues. Lack of skill, lack of time, lack of setup, all those things, all the process, all the stages we are not following. This is unfortunate. And multidisciplinary approach for cancer care is also applied in few facilities. So I can say we have a long way to apply the standard of counseling, apply the standard of breaking bad news, and even applying comprehensive care to cancer patients. This is unfortunate, but with time, I am optimistic things will get improved.
Okay, thank you very much, Doctor. So we have another question. It might be unrelated to this topic, but here it goes. So questions about the details of end of care or life support in Ethiopia. What is the protocol?
Yes. End of life support, terminally ill patient. intubated, or mechanical ventilation, whether to continue or not to continue. Institutions should have their own guideline. At the country level, we need a different guideline. Okay, we have a lot of experience during COVID. Terminally sick patient with COVID, not to intubate or not to discontinue intubation. All those things, these are the dilemmas. It depends on the patient wishes or parent wishes as well as institutional guideline. Unfortunately, many institutions, as far as end-of-life support is concerned, there is no guideline. Even at country level, we don't have a guideline whether to continue for this group of patients or not to continue. For which group of patients do we continue? So some of the ethical challenge we are facing daily in our practice, not only for cancer patients, for any other patient, which are complicated. And we know the patient is not going to survive, but they are on mechanical support. This is a dilemma and a challenge. In this case, what we do, we sit, discuss with the family in a multidisciplinary team, and the family, the multidisciplinary team, will decide on whether to continue the life support or not. It is a big challenge all over Ethiopia. It is unfortunate. We need to have a guideline. Unfortunately, we don't have any from the National Ministry of Health.
Okay, thank you very much, Dr. Mamude. So the next question is breaking bad news to children appropriate for their age?
Yes, children, depending on their development, they perceive issues in different ways. Infant, or up to the age of 3 years, they may say dying, is sleeping, okay? Or somebody who is dead, or they lost somebody as if they have gone somewhere, okay? So we need to consider the development. By the age of 8, it is different. By the age of 12, it is different. They will say this is permanent. After the age of 8, most of the children, they know. After the age of 8, they know this is something permanent. There is no reversal of this. But before the age of 8, most of them, they may equate it with going somewhere or sleeping or something has gone, will come after some time, or they may say, I will go also there. All these things are depending on the development of the child. So children under 14 years, even when you come to consent, it is a challenge. Sometimes 10 to 14 years, they need to be involved in any consent that is called assent. The family, the patient need to sit down, discuss, and both of them should agree. But when it is less than 10 years, the family usually decide. And the professionals will take now a role when the family decide against the best interest of the patient. The professionals have the right to look for another support from legal or any other regulatory body who are supporting the best interest of children. So it is age dependent, not only age, developmental level of the child dependent. So it varies.
Okay, doctor, thank you very much. Because we can address one question and end the session. So the last question is, you told us if the family wants spiritual involvement, we better link them. But sometimes family may hear the diagnosis and want to go for prayer with prophets, declining the medical treatment or other options. How do you see this ethically wise? Do we allow the family?
Yes, it is already said. If they need religious involvement during the process of counseling and breaking bad news, we can allow. In Ethiopia, it is not well known, but when you go to other countries, including some African countries, people they have their own priestess. Okay, if they want that priest to come and attend the session, that is allowed. If they can come, that is allowed. They can join the counseling process and breaking bad news process. They can also be allowed to seek spiritual support during cancer care. But they should go as much as possible hand in hand. The medical service as well as spiritual care, cultural care, family support, all allowed as long as the medical treatment is also going. But when you go to the traditional medicine, herbs, roots, sometimes it is not easy to safely combine with the medical treatment, so that may not be allowed. Scientific medicine may not be allowed, but prayers, spiritual support, psychological support, family support, all those things are part of the treatment. They can be involved in patient care.
Okay, thank you very much, doctor. So, on behalf of Blue Heads Ethiopia and all our participants, I would like to thank you. We would like to thank you for taking the time to present on our session. It was a very amazing presentation and an important topic as well. So we would also love to thank the Ethiopian Society of Hematology and Oncology for collaborating with us to presenting multiple seminars in oncology and hematology topics for the previous sessions and as well as this one. So Dr. Mamude, if you have anything that you want to address to our participants, at least let me give you the chance.
First of all, I would like to thank all the participants who have shown interest and have taken their precious time to attend this session. I would like to thank you all and for asking questions and giving comment. Second, I would like to thank Blue Health Ethiopia for their excellent work. Such type of sessions should have been there for many years ago. In other parts of the world, they have been utilizing such type of platform for capacity building, for information sharing, and for training. I would like to thank you, Blue Health Ethiopia. Please keep it up. This is a very good work, amazing work. Please keep it up. And finally, I would like to thank also Ethiopian Society of Hematology and Oncology for giving this opportunity, especially Dr. Mulugeta, to present this session. And the last, I would like to thank St. Paul Millennium Medical College also for giving me chance to get skill and knowledge on this area. Thank you so much.